Okay, so to wrap up, there's a fair amount of overlap in what Jen's been through, and I suppose it's a good segue into what I'm going to look at. So these are the learning objectives which were highlighted in the invitation. So in summary, clinical assessment of the optic disc, the Humphrey visual field, retinal nerve fiber layer, and ganglion cell layer OCT are complementary for the diagnosis and ongoing management of glaucoma. And in 2021, we need to use all of them. The next two cases show two patients with both with normal visual fields. The first case has a normal looking optic disc with a healthy neuroretinal rim, a healthy retinal nerve fiber layer and ganglion cell layer OCT, and most probably has physiological cupping of the optic disc. The second patient also with normal visual fields, but cupped optic discs, retinal nerve fiber layer and ganglion cell layer thinning, has preparametric glaucoma. And this stresses the importance of being able to use multiple modalities in making the diagnosis. Going back, starting then with one of the four things that we need to do to make a diagnosis of glaucoma, looking at the optic disc. Important for the diagnosis of glaucoma and evaluation of progression. And optic disc photography may be useful when looking for progression, although a number of studies have shown that there is significant intra and inter-observer there's only moderate intra and inter-observer reproducibility, and the results are not that accurate. When documenting what a optic disc looks like, we need to do more than just document the cup to disc ratio. We need to measure the size of the optic disc. We need to look for hemorrhages. We need to not only look at the cup to disc ratio, but pay specific attention to the neuroretinal rim. And we should have a look at peripapillary atrophy. Retinal nerve fiber layer defects are most probably better examined with the OCT. So there is a great variation in the size of the normal optic nerve, and the size of the cup is linearly related to the size of the optic disc. We should measure this either with our direct ophthalmoscope using the 5-degree target, or measure it directly at the slit lamp, making an appropriate adjustment depending on whether we're using a 60, 78, or 90 diopter lens. If we do not consider the size of the optic disc, there's a risk of missing the diagnosis in glaucoma in eyes with small optic discs and overdiagnosing glaucoma in eyes with large or asymmetrical optic discs. Disc margin hemorrhage is a giant red flag for progression of glaucoma. It's most commonly seen in normal tension glaucoma at the infratemporal or supratemporal disc margin. As mentioned earlier, we need to be documenting the neuroretinal rim, not only the cup to disc ratio. And if our neuroretinal rim does not follow the isn't rule, we should be suspicious of glaucoma. Beta peripapillary atrophy may be the earliest or only sign of glaucomatous damage in a small optic disc. It correlates well with visual field changes, and we need to make an assessment of it. So that's what we would do on a clinical examination to make a diagnosis of glaucoma. What do we look for when we're looking for progression? Well, as mentioned earlier, hemorrhages, progressive rim thinning, widening of a notch, widening retinal nerve fiber layer defects, vessel shifts, increasing beta papillary atrophy, and pallor. These three photographs, which were taken 3 years apart, show a normal looking neuroretinal rim supratemporally in the first photograph, with significant thinning in the latter years, and this was preceded by a disc margin hemorrhage. Moving on then to visual fields, and I know Jen did cover a number of these things. Effectively, what we need to be aware of is the reliability indices, and also need to stress that although this field is identified as having low test reliability because of the fixation losses, this particular patient has a reproducible, consistent visual field defect, although she was never able to actually produce a reliable visual field. Just going through what we document here, these are the numerical values, and the grayscale is just a representation of that. Total deviation, if I could just go back, total deviation is the how this particular visual fields differs from the normal database, and pattern deviation takes into account media opacities. The glaucoma hemifield test marks scotomas superior and inferior to the horizontal midline, and if there's a difference between those two, it will be outside the normal range. So when we're looking at retinal nerve fiber layer and optic nerve head OCT scans, we need to evaluate three important parameters before interpreting the scan. We need to make sure that the signal strength, as identified up top here, is greater than 7. It should be well centered on the optic disc, otherwise we would get incorrect measurements. We need to make sure that the scan is actually in the appropriate area and we're actually measuring the correct tissues. So retinal nerve fiber layer and ganglion cell thickness have both been shown to be of similar diagnostic accuracy for detecting early, moderate, and severe glaucoma. Ganglion cell complex is especially useful in patients with peripapillary pathology, as the retinal nerve fiber layer scans are particularly unreliable in those situations. And ganglion cell complex can detect glaucoma changes in more advanced disease. This is because of the floor effect, as the retinal nerve fiber layer basically bottoms out due to residual non-neural tissue. And in advanced glaucoma, visual fields and ganglion cell complex are more likely to show or be of value in detecting progression. When looking at progression, it's useful to use one of the available software packages. This particular printout is from the glaucoma workplace, where there's actually progression analysis on the mean deviation, on the average retinal nerve fiber layer thickness, and this particular software assesses the ganglion cell complex as the ganglion cell layer and the inner plexiform thickness. What you may or may not be able to see here, but there is a suggestion that there is progressive retinal nerve fiber layer and ganglion cell layer loss in this patient. A take-home message from today is, if there has been an intervention and if you have lowered the intraocular pressure, you need to reset your baseline. So if you compare these two scans, it appears as if there's been retinal nerve fiber layer and ganglion cell layer loss in the most recent scan, although if you reset the baseline, you'll notice that that is not necessarily the case. A progressive loss or a trend which has got a greater than 1 or -1 would suggest that that patient has uncontrolled glaucoma, and we need to do something about intervening in that case. So why is it important? Well, we know from studies done in the 1980s and 1990s that we can lose as much as 35 to 40% of our neuroretinal tissue prior to there being a functional deficit. We also know that OCT can pick up progressive glaucomatous damage up to 2 years prior to visual fields, and it may be able to detect progression within a shorter follow-up time in early glaucoma. So moving on then to glaucoma management, like all other disease, it's a balancing act between the severity of the disease and the risk of progression versus the risk and complications of treatment. We should be setting a target intraocular pressure, and this is taken from the American Academy of Ophthalmology's preferred practice pattern. And it's recommended that once we've made a diagnosis of glaucoma, that the initial target pressure be at least 25% lower than the pre-treatment IOP. We should be treating to target, and we should be either referring patients or escalating treatment if they are progressing or they are at moderate to high risk of progression. So traditional glaucoma treatment paradigm, and this was pre the National Eye Institute trials and MIGS, was patient presented with glaucoma, they got glaucoma drops. If that didn't work or they were on maximal medical therapy, we went on to glaucoma laser. That would followed by glaucoma filtering surgery. Following the NEI trials and the advent of MIGS, we now often offer glaucoma laser as a first-line treatment with or without glaucoma drops, and we usually consider MIGS surgery with or without cataract surgery prior to progressing to glaucoma filtering surgery. So which patients should be referred or considered for escalation of their treatment? Well, those patients who are progressing, have uncontrolled intraocular pressures, patients with neovascular, uveitic or traumatic glaucoma, patients with congenital or juvenile glaucoma, and patients with a strong family history of blindness. Here is a follow-up evaluation, again taken from the American Academy of Ophthalmology, looking at when we should see our patients again and which patients should either be referred or timing of follow-up. Take specific note of when there is progression. Those patients need to be seen promptly and intervention taken to correct that. And if the target intraocular pressure has not been achieved, again, appropriate escalation of treatment or referral would be appropriate. Briefly looking at the traditional medical management, there are a number of agents which can be classified either as inflow agents or outflow agents, those that work on aqueous suppressants or those that work out on increasing the outflow either through the trabecular meshwork or the uveoscleral route. The prostaglandin analogs work through the uveoscleral route, and the miotics and neurokinase inhibitors through the trabecular meshwork. Newer medication which has been available in the US and Europe since 2018 are the nitrite oxide donating prostaglandin analogs and the rho kinase inhibitors, and hopefully they will be available in Australia in the not too distant future. So when looking at traditional medical management and how do we manage our patients, we tend to start with the smallest possible dose on at the least frequent as possible, usually using a prostaglandin unless there's a contraindication, and then tend to add in a topical carbonic anhydrase inhibitor unless there is sensitivity. Thank you.